Good morning. Thank you. Good morning. And on behalf of the Foundation for Women and Girls with Blood Disorders, I'd like to welcome you to our second annual Satellite Symposium here at ASH. This morning's Satellite Symposium is Complex Cases in Pregnant Women with Blood Disorders, Hemostasis, and Thrombosis Issues. We have a wonderful program here for you this morning, and we have some marvelous speakers. For those of you who may not be familiar with the Foundation's mission, our mission is to educate healthcare providers about the unique needs of women and girls with blood disorders, so that ultimately all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To help us achieve our mission, we've assembled a wonderful medical advisory committee who have diverse interests in reproductive issues and blood disorders. Two of our medical advisors are on the program today, Shannon Bates and Maggie Ragney, and they, as well as other members of our medical advisory, helped plan this program today. After the program, I hope that our educational mission will stay with you through our website, which can be accessed by typing in Foundation Women Girls in Google or by going directly to fwgbd.org. One of our features, besides our resource library, where you can download articles for free, is our Ask the Expert section, where you can access our medical advisors, and we try to get an answer back to you within 48 hours. So thank you for attending this morning, and I would like to also take this opportunity to thank two of our major contributors whose funding helped make this program possible. The Hemophilia Center of Western Pennsylvania and CSL Behring. And then it is my distinct privilege and honor to introduce our moderator today, Dr. Margaret Ragney, who's known affectionately to us as Maggie. Maggie is Professor of Medicine and Clinical Translational Science in the Division of Hematology Oncology at the University of Pittsburgh Medical Center, where she is also Director of the Hemophilia Center of Western Pennsylvania. She has been involved in multiple NIH grants. She's also a medical advisor to the National Hemophilia Foundation, our Foundation for Women and Girls with Blood Disorders, and is going to talk to us today about von Willebrand disease type 2B in pregnancy, as well as moderate the session. Thank you, Dr. Ragney.
Okay, great. Thank you. Okay, thank you and good morning. We really look forward to an exciting 4-hour session. We're just delighted to have our outstanding faculty who are all physician researchers and expert in the complexities of blood disorders complicating pregnancy. So the purpose of this symposium is to provide a practical case-based review of the latest therapies and evidence-based treatment guidelines for managing challenging problems in pregnant women with blood disorders. So just before we start, though, I have a few housekeeping issues. First, to assure that we provide you with 4 hours of AMA Level 1 CMA activity. Each speaker will have 25 minutes followed by 5 to 10 minutes of questions. Then we will use an audience response system to visit case questions at the start of each presentation and then revisit those questions with the answers at the end of each presentation. We would really like to thank Duke University for providing the CME accreditation and the Foundation for Women and Girls with Blood Disorders for supporting and developing this symposium. A couple reminders, please return your clickers after we're done with the audience response questions, and also ASH has a program evaluation which you will need to fill out before you leave. So without further ado, I am absolutely delighted to introduce our first speaker, Robert Brodsky. He is the Johns Hopkins Family Professor of Medicine and Oncology, the Director of the Division of Hematology, and the Edith Harris Lucas and Claire Lucas Chair of Hematology. His major research interest is in aplastic anemia and the development of novel assays for the study of disorders of hematopoiesis. This morning he will be presenting a talk entitled Paroxysmal Nocturnal Hemoglobinuria. Brodsky.
Thanks, Maggie, and thanks to the organizers for inviting me. These are my disclosures. I'm going to start with a case of a 15-year-old girl that I met several years ago who was complaining of heavy menses and bruising, and she was started on oral contraceptives with no improvement. 4 months later, she started to complain of some fatigue and dizziness. Her labs showed a hemoglobin of 11.5 grams per deciliter, reticulocyte count of 2, white count 3,600, 33,000 platelets, and elevated LDH at 1250. She had a hypercellular bone marrow, about 60% cellularity. Actually, it was kind of normal for her age, and then erythroid hyperplasia, and some normal cytogenetics and no stainable iron in the marrow. 6 months later, she had some increasing fatigue, and she started to be missing school because of excessive fatigue. And then she had an episode of Coca-Cola colored urine, and PNH flow cytometry was performed. And this just shows the PNH flow cytometry, and I don't know if people aren't familiar with this. It's kind of hard to see from here, but anyhow, what we do is we gate using side scatter and forward scatter on the granulocytes and monocytes, and then stain them with monoclonal antibodies. And the PNH population can be seen here in a patient with FLAIR negative and CD24 negative granulocytes. And this is how she was diagnosed. 5 months later, her hemoglobin dropped to 8.4, and she was started on prednisone. And then she started to have TIA-like symptoms, and an MRI was performed, and it showed multiple small infarcts in the brain. And she was started on warfarin. At 18 years of age, she became eligible for one of the first phase 3 trials of eculizumab for the treatment of PNH, and she was enrolled in the Shepherd study and actually did quite well with that. Her hemoglobin went from 7 up to 10.5. Her LDH came down to 300 from 3,300, and she became transfusion independent and asymptomatic. At age 21, after being on the drug for 3 years, we had a discussion about whether or not she wanted to continue on lifelong anticoagulation, because information was coming out that eculizumab was very effective at decreasing thrombosis, and she just elected to come off anticoagulation and has been off ever since. Now she's getting older, and she's actually got married, and she's planning to start a family, and just recently came in and pretty much had 4 questions for me. I have PNH. I'm thinking of starting a family. What's the risk to me? What's the risk to the baby? Should I go back on anticoagulation? And should I continue on eculizumab? And these are the questions that I'm going to try and address. And I'm going to try and give you all the evidence-based answers, but I'm going to tell you right now, there are none. Because this is a very rare disease, and this drug has only been around for since 2007. However, we have learned a lot about the drug, and we do know a lot about the biology of the disease and the drug, so I think we can make some recommendations. So with that, we'll launch into the first question. You heard me mention eculizumab. Which of the following statements is true of eculizumab? A, it often improves the platelet count in PNH. B, it works by interfering with CD55 and blocks extravascular hemolysis. C, it increases the patient's risk for acquiring neisseria infections. D, it does little to decrease the risk of thrombosis in PNH patients. And E, it is a monoclonal antibody that selectively targets and kills PNH cells. I'll let everyone vote. Okay, so pretty good spread. The most common answer was that it increases neisseria infections. Here's question number 2. Which of the following statements is false concerning pregnancy in the setting of PNH? A, there is increased risk of mortality for the mother. B, there is increased risk of mortality to the fetus. C, eculizumab does not readily cross the placenta. D, peripheral blood counts often improve during pregnancy. E, breakthrough hemolysis may occur on standard doses of of eculizumab. Okay, pretty good spread there too. All right, well, hopefully we'll increase these percentages, and I'm going to launch into a little bit of a discussion about PNH. This is an acquired clonal stem cell disorder. It's caused by a gene known as PIGA. It's on the X chromosome, and the product of PIGA is necessary for the first step in the biosynthesis of GPI anchors. As a consequence, PNH cells are missing a whole class of GPI anchor proteins. Two of the more important ones are complement regulatory proteins known as CD55 and CD59. And this just shows the biosynthetic pathway. This is a post-translational event. Interestingly, there's about 10 steps and over 20 genes that are involved in making the GPI anchor that occurs in the endoplasmic reticulum. PIGA is one of 7 genes involved in the first step. So the anchor is made, the protein attaches to the anchor, and then it goes up to the plasma membrane where it resides in the membrane rafts. In PNH, if you have a mutation in PIGA, you can't make the anchor, and if there's no anchor, there's nothing for the protein to attach to, and it's degraded intracellularly, and you're missing the whole class of proteins on the cell surface. And this has a lot of devastating complications. And I won't drag you too much through the complement pathway. I'll try and simplify this. But there's 2 major proteins that are missing. There's one, CD55, that blocks C3 convertases. And then there's another one known as CD59 that works down here in the membrane attack complex. Complement can be activated by a number of mechanisms, and once you get to the C3 convertases, C3 activates C5, and then C5 is split into C5a and C5b, and it is C5b that oligomerizes with C6, 7, 8, and multiple 9 molecules to form the membrane attack complex. What CD59 does is block the formation of the membrane attack complex by interfering with C9 incorporation. And again, CD55, which is the other GPI anchor protein that's missing in PNH, works up here on these C3 convertases. So, this just shows the effect of terminal complement on red cells, and red cells are really most vulnerable to complement-mediated destruction because they're in many ways just a balloon. This is a red cell shown here with these GPI anchor proteins or complement regulatory proteins on the cell surface depicted in yellow. So when there is complement activation, as there always is through the alternative pathway, it's cleared and the red cell isn't lysed. It only takes a single membrane attack complex to land on a red cell to lyse it. So this is a very effective mechanism. In PNH, you have a mixture of the normal cells and then the PNH clone, which is missing the GP anchor proteins. And because you are missing GP anchor proteins, you're missing complement regulatory proteins. So when complement now lands on this population of cells, the membrane attack complex forms and it pokes a hole, and this cell will swell and actually burst. The other important thing is that free hemoglobin is released from the red cell, and this causes a lot of the pathophysiology of PNH. It's not just the hemolytic anemia, it's the release of free hemoglobin, because free hemoglobin is a very potent scavenger of nitric oxide, and this causes a lot of the symptoms that PNH patients often complain of: severe esophageal spasm. Men will often complain of erectile dysfunction. The fatigue is also contributed by this, and it also contributes a little bit to the thrombosis and renal failure. So here's our complement cascade again, and now we're going to go over eculizumab and how that functions. Remember, when you have the C5 break into C5a and C5b, that's how you get your membrane attack complex to form. What eculizumab does is bind to C5. And by binding to C5, it blocks the formation of C5a, and it blocks the formation of C5b, and if there's no C5b, there's nothing for the C6, 7, 8, 9 to oligomerize, and the membrane attack complex doesn't form. So what eculizumab does is it is a monoclonal antibody to C5 that blocks the membrane attack complex and actually protects the PNH cells. It doesn't kill them. So there have been several phase 3 trials that we've been involved in, known as Shepherd and Triumph and extension studies that have led to the FDA approval of this drug in 2007. I'm not going to go through all the trials. I'm just going to summarize what we've learned from these trials. And one of the things that we've learned is that these are quite effective and safe drugs with very mild side effects. The big risk is neisseria infections. If you block terminal complement, you are going to make patients susceptible to neisseria infections. They need to be vaccinated before they start on eculizumab. But even vaccinating them, they have about a 0.5% risk per year of developing neisseria infections. So they need to be very aware of that, and so do you as a treating physician. It is quite effective at decreasing intravascular hemolysis because it is the membrane attack complex that causes the intravascular hemolysis. And it decreases or eliminates the need for red cell transfusions in many of the patients, not all. It markedly improves quality of life, and it markedly reduces the risk of thrombosis, almost back to baseline. Drawbacks: lifelong therapy. It has to be given intravenous. It's given every 2 weeks, and it is an incredibly expensive drug, probably one of the most expensive drugs in the world, at about $400,000 a year. Not all PNH patients need to be on this drug, but the ones that have life-threatening manifestations and are having life-threatening strokes or abdominal vein thrombosis, etc., they're the ones that need to be on it. Not as effective in patients with the aplastic anemia PNH overlap. So it doesn't treat bone marrow failure. It doesn't raise the platelet counts or the white counts. Okay, so let's get back to our patient and our question. So what's the risk for a PNH patient getting pregnant? And again, before the eculizumab era, there were basically case reports in small series. But it is very clear that pregnancy was a problem not only to the mom but also to the baby, and there were a lot of complications. Fewer than 100 cases reported, and again, this is all subject to publication bias, but a lot of maternal mortality, up to 20%, largely from thrombosis. and again, a significant amount of fetal mortality, up to 10%, largely from thrombosis. Preterm delivery, about 50%, and there's also a high incidence of worsening anemia and thrombocytopenia in these patients during pregnancy because there's usually some underlying bone marrow failure. There have been 5 reported cases of successful outcomes in PNH patients treated with eculizumab throughout the pregnancy. And the reason there's so few cases is the phase 3 trials excluded pregnancy, but now there have been 5 cases. Eculizumab does not cross the placental very well, and if you look in the cord blood, in some patients you can barely detect it, but not at levels that would come anywhere near interfering with complement. It also doesn't appear to get into the breast milk. So most of us who treat a lot of PNH are much more scared of pregnancy and PNH than we are the eculizumab. The other important thing to remember in dealing with pregnant women on eculizumab is towards the 3rd trimester, especially in women who have gained a lot of weight, the volume of distribution can change. And what you'll see is the dose that was controlling complement and controlling their hemolysis no longer does in some patients. And that's usually manifest by a rapidly rising LDH and a return of their symptoms. So you need to be aware towards the 3rd trimester that you may need to increase the dosing. So what did I recommend to our patient? Planned delivery. We monitored her closely for cytopenias, and so far she hasn't had any significant cytopenias. She's on iron, folate, B12, all the usual things. Most of us still recommend initiating low molecular weight heparin. We don't know whether that's necessary, but there's been such a history of thrombosis in this that we are often a little cautious there. I put her on prophylactic heparin. People who have active thrombosis and a recent clot, you might want to put them on full dose and then switch them to unfractionated heparin around delivery. But again, there's not any evidence based around this. And then carefully monitor for breakthrough hemolysis in the 3rd trimester, and you do that with just monitoring the CBC, the reticulocyte count, and the LDH before each dose of eculizumab. So what you'll see if they're breaking through is not only will they start to have symptoms, but their LDH and the reticulocyte count starts going up. And if you see that, you might want to take the 900 dose and up it to 1200. All right, so we'll go back. Let's see how we do on the questions this time. Which of the following statements is true of eculizumab? It often improves the platelet count in PNH. It works by interfering with CD55 and blocks extravascular hemolysis. It increases the patient's risk for acquiring neisseria infections. It does little to decrease the risk of thrombosis in PNH patients. It is a monoclonal antibody that selectively targets and kills PNH cells. Wow, good job. So, all right, well, let's see what we do on the other one. Look at this, evidence of learning. Question 2. Which of the following statements is false concerning pregnancy in the setting of PNH? There is increased risk of mortality for the mother. There is increased risk of mortality to the fetus. Eculizumab does not readily cross the placenta. Peripheral blood counts often improve during pregnancy, and breakthrough hemolysis may occur on standard doses of eculizumab. Okay. Yeah. So the D is the peripheral blood counts often improve. They often get worse during pregnancy in PNH patients. Eculizumab does not readily cross the placenta. It crosses a little bit, but not enough to interfere with complement. And there is a marked increased risk of mortality to the mother and fetus. And I think that is it. So if there's any questions, I'll be happy to take them.
So ask them to come up to the microphone.
Okay. Yep.
So this is a question not related to pregnant women, general question. Is thrombosis alone is an indication to start eculizumab?
I'm sorry. So your question, I think, was: is thrombosis alone an indication to start eculizumab? Yes.
Without significant hemolysis.
Yeah. These patients tend to clot right through heparin and warfarin, and the only thing that I've really seen that stops thrombosis in PNH is complement inhibition. And I'll also mention that that's prior to eculizumab, the leading cause of death in PNH is thrombosis. Yes.
Mathematics, Maryland. Have they established the risk factors for this disease since it is so rare? Is that something that is known or not yet?
So the question was, are there established risk factors for acquiring PNH? Really, no, with the exception of patients with acquired aplastic anemia have a very high risk of developing PNH. About 2/3 of patients with acquired, not inherited forms, but acquired aplastic anemia will have a small PNH clone at diagnosis. And over years, about 15, 20, 30% of those patients will go on to develop PNH. But the classical form that doesn't come out of aplastic anemia, there's no known risk factors. Okay. Oh, we got one more.
Can the PNH clone be reversible also?
I'm sorry, I missed that.
Can the PNH clone be reversible?
Can the PNH clone be reversible? Yes. And it's interesting. It's not common, but some of these patients will have their PNH clone regress over time, and we've had about 10% of our PNH patients who are on eculizumab have a decrease in their clone size, and it doesn't completely go away, but it goes down to a level where I'm almost starting to think about stopping the drug in some of the patients. So it's rare, but it happens. Okay. Thanks. Oh, I gotta set up.